So this one is about how to survive a trauma meeting. We all have to be sitting there, whatever our roles is, and we'll have to take part in these trauma meetings. So Shahir, we're gonna tell us, as he says, part of his daily routine. He's gonna tell us how we should survive it. Over to you, Shahir.
Yeah, thank you. Thank you so much, Faraz. This is something that, as Faraz mentioned, we all go through. And for a lot of people that probably aren't familiar with how an orthopedic department is, it comes as quite a bit of a shock. So I've had a little bit of experience before I started my core surgical training job, which is an SHO level job if we have colleagues here that are not junior doctors. And it's interesting. So I thought this would be something interesting for people from different backgrounds to be able to get some context on, and hopefully then participate in and get the most out of it. So my name is Shahir. I'm a TNO team core surgical trainee based in Glasgow. There's a little teaching platform that we run as well, and I'll talk a little bit about at the end. But I'm going to start with where TNO sits. So sometimes it's easy for us to skim over the importance of MSK disease and injuries. And basically 20% surgical intervention within the NHS are MSK diseases. I think something around a third of referrals from GPs into hospital are MSK related. So, this is set to significantly increase over the next 10 years. The annual budget for MSK is about £10 billion. It's the third largest budget after mental and cardiac health. 25% of the population will be over the age of 65 by 2035, and waiting lists are huge. There's something like 300,000 people on it. So it suffices to say that a multidisciplinary team in MSK disease, covers a lot. And it's something that is a daily occurrence. And for many of us that have no exposure to it, it can be a little bit daunting or sometimes confusing about what's going on and where do I fit into all of this. And much of what happens in TNO starts at the morning meeting. So, what to expect. And what I would say is that, you can look at this from different perspectives. As a non-medic, if you're participating in the trauma meeting as it's an MDT or a multidisciplinary meeting, then, you have to take a step and realize what is your role today, or how are you participating in that team? So if you are a trauma coordinator or if you're a physio and you're a part of that meeting, then you may come across patients being discussed that you have come across, and your input would be very valuable. So, understand when you need to speak and when you can or should be heard. So hopefully we'll come across how we can do that. As a junior doctor or a individual that has just landed into the world of orthopedics, it can be a completely new experience if you're uninitiated in how things are run in a trauma and orthopedic department. And it's more of a presentation than a handover. So, I would have colleagues, including myself, that come to a trauma and orthopedic department, and you're used to a handover setting where, you're talking about a patient very, not casually, but in not a show and tell fashion. And you're talking about them and the investigations, and that's it. In orthopedics, it's very similar. However, it's very much more show and tell. And what you're essentially doing is that, you're trying to illustrate an injury or a story, and you're also trying to go along and tell everyone else that, this is what we found, this is what the injury was, this is the vital signs or investigations of the patient. So it's a broad discussion of the injury, and we'll cover some of that. So guys, I think I'll be amiss if I didn't mention some of the resources that are out there, and really are tremendous numbers of resources. So Mr. Arnaud has got a great book here as well. It's more so aimed at people that are trying to get a quick, but also in some areas advanced introduction to orthopedics. There's OrthoHub, there's Ortho Bullets, which can be quite quick if you want to find out a little bit about something. And then there's books. There's accredited orthopedic trauma. There is surgical exposure by Hoppenfield, both books that I've used here and there. And then, shameless plug, our little page that's aimed at medical students, which is the 6 p.m. series. We have small little videos that we covered in Ortho Essentials since medical students told us orthopedics wasn't well covered. And then, you have loads of fantastic videos on the Orthopedic Academy YouTube page. And I've discovered this a while ago. Some of them may be advanced, but if you're interested in that, resources are out there. So what is a trauma meeting? So trauma meeting is usually an early morning meeting to evaluate and triage patients that have come in over a 24-hour period. Now, it's not necessarily just a 24-hour period if you take into account that patients may come in over a weekend and they are handed over to another team during normal working hours. So it can go beyond 24 hours. But for this period, let's say it's a 24-hour period, it's all the incoming patients, and you're going to discuss and triage them accordingly. So it involves usually one consultant-led team handing over to another consultant-led team, and it works in an MDT fashion with collaborative decision-making, and they sort of bounce ideas about how this patient is going to be managed and what would be an optimal time or an optimal theater slot to manage them by discussing it amongst each other, and then looking at any investigations that were carried out. So, it's very important to understand that how a theater and operative list is decided is based on the on-call patient load and ultimately how the trauma meeting goes. Nowadays, this can also take a virtual format. So, our department uses Teams. Other departments have also used Teams. So it's become very hybrid, and it allows you to be a little bit flexible where other members of the team or other consultants in the team can participate and offer their expertise on days that they may not be around or may not be at the meeting. So, that's a good and new change that everyone welcomes. So as a junior, you may be presented or expected to participate. And, that is very much the perspective that I'm going to try and offer, since that is the perspective that I'm familiar with. And, it can be quite daunting. You're sitting in front of a big department, depending on where you are. It could be a couple of chairs strewn together to, a proper lecture theater, which is where I present. And it can be a little bit intimidating, and especially if you're an F2 or if you're even a CT1 and even a registrar in a new department, this can be intimidating. So we'll go through a couple of things. So there's not many pictures in my presentation, but I decided that it's probably worthwhile showing a picture of how it looks like, because if you're a medical student that you're attending today, or even if you're a junior doctor, or you could be a physiotherapist, or you could be anyone from an allied profession that's attending today, and you may have never seen what a meeting is like, then it's very much like this. So on the left, we have sort of a smaller based meeting. On the top right corner, we have what would normally be bigger, so more like a lecture theater. And that's very much it. It's very much like a presentation. And there'll be someone that will be controlling the imaging, someone that will be controlling the trauma board or the list. And as the discussion is going, they're going to triage patients accordingly and then organize the list according to that. Now, on the right corner, we have an X-ray. We have Blue Spear, which is a software, which is a trauma software that we use in our department. I included here. Everyone can differ in what they may use, and certainly everyone uses PACS, and nowadays we all use Teams as well. So how would you take a referral? So there's lots of ways to take a referral, and you might come from another specialty and you have your own work. But what I would say is that orthopedics is very image heavy. So, when you're starting your shift or when you're starting the day or the night, remember that anytime you're having a communication, be image heavy, be image heavy and discuss as you go along. And the way you can actually make the most of that and multitask is get the patient's number and details as quickly as you can, have them up on PACS. And you may not be a whiz in x-rays or injuries at this stage, but what it allows you to do is it allows you to have a pattern in your head, a discussion about the history as you look at that image, and then you can build a story as you go along. And what I would say is if you follow this sort of format, who, what, where, then you'll never really go wrong. And it always helps to keep a list that you can track And I don't know if everyone does this in their department, but you can code the images based on the date. So, images come up in an easy fashion when you're presenting them in your meeting. So there's not very much different here from what you would be used to if you were taking a referral in another department. But yes, it's very dependent on the X-ray or the image, and this will help your colleagues in the meeting then help and decide. So I'm sure you've discussed many, many different injuries and patterns, but we're just going to look at one quick case that you might encounter similar to this quite often when you're on call. So, the NOF is probably the classic orthopedic injury that everyone talks about, and we'll talk about that as well. So it's a 70-year-old female tripped at home, trying to go to the kitchen, fell on their left hip. Interestingly, the patient is taking warfarin for AF and reports hitting their head on the way down, GCS 15, past medical history, AF hypertension, lives at home alone, needs package of care 3 times a day, mobilized with a Zimmer frame, normally stays indoors and go out. Now, there's a lot going on apart from the hip injury there as well. This patient takes an anticoagulant and they've hit their head. And, you need to make sure that, and you would have gone through this in your lectures previous as well, that you look at this patient from a systematic way. You look at the fact that they're frail, they're geriatric, and they are more prone to injury. It's possible that they could be on something that is, lowering their heart rate. In this case, they have hypertension, but, if a patient is on a beta blocker, that might be causing beta blockade. You may not have a good idea what their vital signs are. Assess them in a proper systematic way. And, you can do a primary, secondary survey if there is an elderly trauma patient like this. The other thing is that there's, interesting piece of information here. There's social history, and there's a reason I went into detail in that, because your social history is going to dictate a lot of how the patient is going to be managed. And because of this, it's important that you communicate this as well. And, in the morning, you'll realize how important this really is in the decision-making of what the definitive management for the patient will be. So I've kind of designed communication formats around things that most of us would be familiar with, and an S-bar is something that we're mostly familiar with. So, I've often had a situation where even me and other people have asked that, I get a bit fuzzy when I'm standing in front of people in this sort of a presentation style meeting. What can I do? And, this would be the case for all of us. And what I would say is that, stick to a format that you're familiar with. So if you're familiar with SBAR, build out how you're going to communicate your case in the morning around that format. You're familiar with it, so let's go through it. So, you've got an 80-year-old female here with an intracapsular neck of femur fracture that was sustained after a mechanical fall or a trip. Important, mention that it was a fall or a trip, not a blackout. How did they fall? It's an important piece of information. So then background, and they've got a history of hypertension, AF, managed with warfarin. What's their social history? They mobilize with a Zimmer frame, package of care 3 times a day. So they have high requirements. How is this going to determine my management? Well, it'll definitely go towards the hemi instead of a total route. I know they're an elderly patient, but it helps. The other thing is that you did your assessment. So how did you assess them? They weren't able to move their leg, they were painful on pin rolling, they're neurovascularly intact, and you examine them for the distal pulses and sensation, and you've marked their limb, and bloods are done, and you've got their INR. So, INR, why is this going to be important? Well, if a patient needs spinal, if we're worried about the patient's INR being too high and they probably aren't in a good enough position from a bleeding point of view. And, bloods, the standard stuff, group and save, what's the patient's hemoglobin, and we'll discuss a bit more of that later on. And then the last thing what is your recommendation? So your recommendation at a junior stage might be in discussion with a senior. So you might have discussed it with a registrar who, would have talked to you about this patient having a hemiarthroplasty, and they're marked and consented for that, discussion with anesthetics for INR and warfarin. So if you follow a format where you're actually familiar with the structure of that format, then each time you are communicating a piece of information, you can do it in a flow where it doesn't feel unnatural, where you don't feel like you're jumping about. And this is something that we underestimate, because I feel like at times I'm jumping about. And the best thing that you can do is to, beat it down to a structure. And each time then, you've covered all your bases. And if there's anything else that someone needs to ask, they can ask you afterwards. So preparing your list. So admissions in a 24-hour period, this is usually what's going to be in a list. It's usually not just limited to 24 hours. You could have patients over 48 hours. You could have patients that have been on the list all week, but for whatever reason, whether they need discussion, they're a complicated revision, they're a patient with a complex trauma that needs to be transferred, awaiting transfer, awaiting repatriation. There's lots of reasons that patients can remain on the list. So always discuss if a particular patient needs to be on the list or not. And the best thing is to discuss this with your seniors. Be attentive if you're the overnight on call. So, and if you're not familiar with this experience and you're coming right into it, the person that is overnight is basically the person that is probably going to chase the bloods, is going to optimize patients that are still awaiting optimization and discuss it with anesthetics or anyone else, any other teams that are involved, as well as manage the on-call. And in most places, be the only person there if there's no F1 around or there's no other support around. And that is the situation I've often found myself in. In fact, that is the situation in our department. And for a big hospital, that can be challenging. So, list patients based on injury. We'll talk about this as well. Have a golden patient. Try to communicate this with your team early on. If unsure, who is the golden patient for the next day, ask your registrar that's on that day. Or if it's during daytime hours, even go ahead and ask your consultant or ask a trauma coordinator. People that would be able to give you those answers, make sure you clarify that, because once you go into the night stage, then someone might be expecting a patient to be golden, and you're not aware of that, and that can always be troubling. Investigation should be updated whenever possible. So if you have a list and there's a patient that's just come in but they haven't had all their investigations, when you take your handover from your colleague, make a list of people that you need to chase investigations for, and then make sure you update them on the list as they are done. And this can be difficult, and if you don't have a list, it's even more difficult. So try and keep track of everyone that needs investigations updated. This can be something as simple as group and saves to a patient that's lost a lot of blood, and you need to have a look at their hemoglobin and see if they require any more transfusions, or any other kind of optimization. And the last thing I would say is prep the list early. And oftentimes what happens is that you leave it too late. And this is a trap that we all fall into. Most trauma meetings are around 8. So try to have the list and everything done and printed and stapled by 7:45. So a rough template, because some people are sometimes even not familiar with how they should have a patient or someone that's come in stated on the list. This is a rough template, okay? So the way I do it is very similar to what you would have in your clerking book. And the reason I do it like that is, say you need to send a referral, you copy and paste this, and whatever software system you have, you send the referral through that. Say you are getting your referral over the phone, and you are just receiving information about this patient. You can start typing it in this fashion, and then you can start your clerking or prepping your clerking as well. So anything you can do to build in efficiency is always helpful. In the next slide, I'll talk about how and why this is helpful and what communication this is displaying to people that will be looking at that list. So you've got your injury on the very top, and you've mentioned that this is a golden patient, and that may be after discussion with other team members. But you've also mentioned how they got the injury. You've mentioned their past medical history, and some may or may not have an echo, or you're worried about a patient with heart failure and they may require an echo. Having any kinds of information like that will help the anesthetist will be helpful. And then key informations that can lead to a case being cancelled. So hemoglobin, sodium, group and save, potassium, vital signs. So are they pyrexic? Are they apyrexic? Do you think there's any other infection that might be going on? Are they able to consent? or have a conversation? If they're not, what do they need? Do you need to have a discussion with family? Do you need some collateral history? And then, the next thing, social history. I think this is quite important. And, you should always try and get as much social history as you can, because particularly in hip fractures, this can make a big difference. And, marked and consented, are they ready to go? And DNA CPR. This is something that we're probably guilty of not doing as much. And, it's a discussion that we should probably aim to do more in orthopedics, because a lot of our patients tend to be very frail. And if we don't have this discussion, then, we really have no leg to stand on if they then deteriorate further. Okay. So I included this one paper that I felt was very, really useful. And the reason I found that was useful for anyone that's watching here is that in the paper, they not only discuss guidelines for management from an anesthetic point of view, but they look at reasons for delaying surgery. So if we went to our previous slide, we talked about those things that are highlighted in green, hemoglobin, sodium, potassium, diabetes. All this kind of stuff is going to be very, very useful if the patient has any uncontrolled or acute onset left ventricular failure, arrhythmias, infection, coagulopathy. These are really important things. So if you include them like that in your list, it's not just the orthopedic surgeons that are viewing, it's everyone that's involved. And, that will be your trauma coordinators, that will be other SHOs, that will be the anesthetists, that will be people in theaters, that might be people that are physios or nursing staff that are also present there. So, it can really vary from department to department. And, the more clear that information is, the easier it is for you to get through the meeting. Optimizing your patients. So this may not necessarily come up as surviving a trauma meeting, but if you optimize your patients and you include that information on your list, it's always going to help you out. And this could be things like, have you had a discussion with hospital at night, medics, anesthetists? Is a patient got new fast AF? Have you discussed with the medics what you think would be the best thing to do? You've decided that a patient is golden. Have you discussed them with the anesthetic team that if they can be done in the morning and get a review, bloods, transfusions, electrolytes, all of this stuff? If you first get information about a patient and you start figuring out that this is how I'm going to present it, and these are the things that will prevent this patient from getting surgery or definitive management, then your optimization pattern will be in tune to that. And this takes time and experience, and a lot of us will just be continuing to figure it out. So don't necessarily get too stressed. Seek advice wherever you can if you're worried about something. Right. So trauma list order. Now, I might be relatively inexperienced in this as a CT1, but what I would say is, trust your judgment. If you think something makes sense, and if you don't think it makes sense, then discuss it with your seniors. And how I would say you would order your list. Now, some places may have this function based on the software, like the Blue Spear software we had actually ranks patients based on neck of femur fractures and everything below. So, ask your seniors what is their priority for management, and order your list according to that. So, have a designated golden patient if there is one, NOF patient with type 1 diabetes. You might often want to list them first. Polytraumas, ankle fractures, I've written them down a second here because they can be complex and it requires a discussion to be able to figure them out. So they may not be the first people to get going. Upper limb injuries needing imaging, stuff like this can go afterwards. And then, patients with COVID that need some kind of intervention, or any infection that's going to require deep clean of the operating theater, try and list them last. And then, because those will be the patients that will be managed last on the list, on the trauma list or the theater list, and patients awaiting imaging for discussion. So this could be MRIs and all that kind of stuff. So, you have a case here, and this is something you'll see quite often during an on-call. You have a young person or any person with bilateral sciatica, new episode of urinary incontinence. So, a back pain patient, and you're not quite sure what to do with them. You've been asked to MRI them locally, and locally means tomorrow. The patient is keen to go home. They don't live far away. What should you include in your list? So, on top of your examination, I think there's a couple of things that, for particularly cauda equina or back pain patients, I think it's important to include or to understand. And I've used a commonly known acronym for this again, SPIES. And we may have used SPIES in a different setting, but I think it would be interesting to use it in this setting and allow you to remember all the things to do. So seek as much information as you can. What's the patient's proximity to the hospital? Patient's phone number, do not forget that. Reason to be an inpatient or not to be an inpatient. So if you feel the patient is relatively high risk and it's better if they're an inpatient, that means they can get their scan quicker. Then find out why do they not want to be an inpatient, and document all of that. Patient safety, advise on red flags, returning advice, reassuring signs. So do a post-void bladder scan, a PR examination, all of this stuff, and document everything. And book an MRI in advance. So show your initiative, provide the patient with information presenting for the scan, where to go, what would be the easiest place for them to come up to, and then. Oh, something happened to my screen. Apologies. Can everyone see me?
Yes, Shahir. Okay. That's fine. It's went off for a moment. I think you probably just need to reshare your slides. Yeah.
Can you see it now?
Yes, you were on call. Yeah.
Hello?
Non-active. Yeah.
Yeah, okay, no problem. Okay, sorry about that. Yeah, so, and the last thing is offer support and see if you can make the patient more comfortable in hospital. If they choose to go home, then offer them an advice booklet or, analgesia before discharge. And, similarly, this is the last thing, by the way. If you were on call overnight, you ran into a patient with rapidly spreading aggressive cellulitis, unstable vital signs, and this is happening in the night, early hours of the day. Call your registrar. They make not a neck a neck fascia, necrotizing fasciitis. Sorry about that. It's autocorrect. Is made, and they operate on the patient in the early hours, and you are the only member of the night team in the morning trauma meeting. So unforeseen circumstances. What are you going to do? So stick to what you already know. Regardless of these situations, the show will go on. And stick to what you know. How much do you know about the situation at hand? Summarize it if you don't know very much, a quick summary, and use your SBAR technique. Don't forget all the good work you put in the call thus far, and make sure you've kept an organized list of everything that's been going on, all the inpatient admissions, and then, delegate. The sick patient that you were worried about that might have, taken up a majority of your last few hours is now under the care of your other team members. So you need to try your best to focus on the meeting. So, anytime there's unforeseen circumstances, you may be in a situation where your frame of mind is being switched off or you're not ready yet for the meeting. The best thing to do is that summarize as much of what you know as you can, and then start going through the things that you've seen properly. So, start listing your patients in order, the patients that you've seen and the patients that you know. So last thing, guys, for many reasons, the trauma meeting remains important. I foresee it to remain important for many of us. It's an important way, and often the way we're judged by our team for our presentation skills, clinical judgment, time management, and always seek advice. Trauma and orthopedics can be very, very specialist. And if you're not sure about something, just ask. And this can be daunting, but it'll help you in the morning if you have asked prior. And don't beat yourself up for days you don't get it right. Trust me, I have had a rough set of nights before I have come to this talk. And there are times you don't get it right. Multiple sick patients. I'm the only one that's on. Multiple patients coming in through the on-call. And I think it's important to remember that this is a marathon, not a sprint. And we're probably doing this for a long time. And lastly, what I would say is be kind. Okay, so be kind to your colleagues. And a small word of encouragement, pat on the back, a little bit of help goes a long way. And if someone does that for you, always try to reciprocate. So guys, thank you so much for listening. I'm about 5 minutes over time. I apologize. And here's some Instagram links. The Orthopaedic Academy have a lovely new Instagram page, so follow them. The 6 p.m. series is a medical student AIM teaching collaborative that I helped co-found. We have some videos on that aimed at medical students, and my Instagram's there as well. thank you so much. And yeah, that's it. Thank you so much, Russ.
Thank you very much, Shahir, for coming on to teach on this course. It's wonderful to have a trainee with us and the faculty for this course, because you represent your own group's point of view very well. And I'm very happy you introduced the 6 p.m. series, which is, I confirm, it's a wonderful platform dedicated to teaching for the medical students mainly, and have a lot of orthopedic related topics. So it's a wonderful platform we have been on, and it's we recommend it to everyone. And well done for founding, be that one of the co-founders of that platform, Shahir. It's a really
Thank you.
excellent initiative.
Thank you.
And
And this is really good.
Yeah.
Aimed at many people at our stage, and even different backgrounds, allied health professionals. Fantastic. Thank you.
Thank you for coming on. Yeah, trauma meeting can be daunting, as you said, and can be a stressful experience. And it's good to have a system, definitely. That's what we like also in orthopedics. Just have a system, just make it simple. Yeah, so I like the S bar.
Yeah, I try to keep it simple.
Yeah.
Things that people will be familiar with, and
Yeah.
SPIES is an acronym people are familiar with. So I created it based on those two, and hopefully people take something away from it, including me.
Yeah. We've all been there, obviously. For most of us, trauma meetings is part of our life, part of our professional life. So we've got to live with it. Yeah.
Absolutely.
And we can always improve it. I think, good.
Yeah.
So we have some questions for you, Shahir.
Yeah, sure.
Good. So everyone wants to know, what is a golden patient?
Yes. Okay. So that's a really good question. So it's fantastic because you might get my perspective, and we have many senior faculty here as well. So a golden patient is really a patient that's been optimized to be first on the list, and that could be a patient that might be optimized from a point of view of injury, or is optimized from a point of view of a patient that really needs to be done that day or has been delayed, but today is the slot that they can be done. So it very much depends on the team. But the key thing I want you to take away is a patient that's been optimized or listed to be done first. And as such, if you are the person that's overnight, you need to make sure that if there's any outstanding investigations or anything that needs to be carried out, then you do your job to get that done.
Thank you. So the golden patient is the patient that has to go first on the trauma list next day. These patients have to be prepared 100%, seen by anesthetist, consented, marked, optimized for surgery first in the morning, no delays. And they tend to be neck of femur patients a lot of the time, but not necessarily always.
Yeah.
So, that's why they're called golden patients.
Yeah.
I think it's quite...
And I think it's an important thing to sort of understand if you have no context to build on for something like this. And it's the thing that would stress you out the most if you didn't know what it was. And, for example, you're on call for the first time and it's just thrown at you. Now you're familiar with the term.
Yeah, exactly. Just for those who asked, the replay will be available right after the course this evening for all the lectures. You can see it through the same login you have. We have one more question for you, Shahir. So first of all, we have a foundation doctor who has wrote a comment that they found your talk very helpful for their next job. So I think that's wonderful to see. Now you've discussed the 7 reasons of delaying surgery, and someone will just want to ask if you could go through those again, if you don't mind, as quick as you can.
Yeah, sure. So this is based on the Guideline for Management of Hip Fractures 2020. It's a well-cited paper that's in the Anesthesia or the Association of Anesthetics Anesthetist Journal. And basically the 7 reasons that they talked about based on a 2011 guideline or acceptable reasons for delaying surgeries: hemoglobin below 80 grams per liter, plasma or sodium concentrations that are hypo or hypernatremic, so 120 or on the high end, 150, and potassium. So potassium can be very important because patients that tend to be hypokalemic are at a higher risk of becoming AFib patients post-operatively. So potassium, for many reasons, they don't want it to be hyperkalemic or hypokalemic. And then uncontrolled diabetes. And this will be important from a healing point of view, but also these patients tend to complicate more if it's not controlled or not optimized pre and also post-operatively. As you may know, that in a post-operative stage or in an injury stage or in a stress situation, so the ability for your body to be able to have diabetic control is difficult, and you need to optimize these patients. And patients with acute onset left ventricular heart failure, and these patients might be complicated for cardiac reasons, and they may require an echo prior to surgery. And any patient that has a correctable arrhythmia or a ventricular rate over 120, chest infection with sepsis, obviously, if you're intubating a patient or general anesthesia, even if you're giving them spinal, this may be important, and reversible coagulopathy. So if the patient's suffering from any kind of coagulopathy and you can reverse it, and we discussed it in the case of a patient taking warfarin, then you want to see if you can reverse that. Warfarin, Pixaban, the Bigatrans, any of the DOACs, they require renal clearance. So you might have to discuss it with either hematology or with your medical team about, is there a waiting time that you should have, and then discuss with the anesthetist. So I may not be, an expert on this, but I feel that these were good points that can help you to triage patients, and paper worth reading.
Yeah, thank you. To be honest, Shahid, none of us is expert here. We are all just advisors, and we're giving our best opinion and from our experience. So I think it's good to have your experience. Yeah, these points can be reviewed again on the replay. Thank you very much, Shahir. We got to move on. Thank you very much for taking part and joining our faculty.